Thank you to the organizers of the annual virtual cardiac conference for allowing me to present our talk today, which is Gynecologic Tumors Involving the Heart. And I prepared this with my supervisor, Dr. Bernardini. I'm a fellow in gynae oncology. I have no conflict of interest to disclose. So we'll go through the common gynecologic cancers and our associations with metastasis to the heart. So we'll go through cervical cancer, endometrial cancer, intravenous leiomyomatosis, endometrial stromal sarcoma, and ovarian cancers, presenting several cases for each one. And so the first case is a 52-year-old female, G2, P1. She had a past medical history of a cerebral infarct at 48 years old, and now presents with shortness of breath, lower extremity edema, thrombocytopenia, and a high LDH. So upon investigation, she was found on transthoracic echo and CT on admission to have a 40 millimeter large mobile mass in the right atrium, which are identified by the arrows here. She underwent an emergency cardiac surgery to reduce the risk of pulmonary embolism and tricuspid valve obstruction. The large tumor was found attached to the right atrial wall between the IVC and the coronary sinus and was excised with clear margins. Here's the final pathology specimen, and we can see the gross specimen and the histology, and the final diagnosis from the specimen was a squamous cell carcinoma metastasis of an unknown primary tumor. So patient went on to receive further investigations and was found on MRI to have a 1.8 centimeter tumor in the cervix. She had a CT preoperatively, but of course that didn't pick up the tumor, as CT is not a sensitive imaging modality for cervical tumors. So that was missed preoperatively. And then this is a speculum examination of the cervix, and we see here at 7 o'clock the area where the tumor would have been. That was biopsied and revealed a cervical squamous carcinoma. So due to the metastasis to the heart, the patient is now a FIGO stage 4B. So the outcome, the patient underwent primary treatment with chemoradiation. There was no mention of whether she received systemic chemotherapy, which would have been thought to be given for distant metastasis. At 1 year follow-up, she had no recurrence. And this highlights a rare case of an isolated cardiac metastasis of an otherwise stage 1B cervical cancer. The differential diagnosis for the cardiac mass on presentation could have been one, a metastasis from a cervical carcinoma, but at the time the patient wasn't known to present with any symptoms, no vaginal bleeding, no abdominal pain, so it was not in the differential at the time. Other differential diagnoses include atrial myxomas, thrombus, a brown fat mediastinal node, or a variable uptake in a normal heart. So the incidence of cervical cancer metastasis to the heart is 1.2%, and this is based on autopsy specimens. The location is most commonly found in the pericardium, and then followed by myocardium in 30% of the time, and then the endocardium for 6% of the cases. And very infrequently, formation of an intraventricular tumor is found. It most commonly affects the right heart. And the median age of diagnosis is 49 years old based on combination of case reports. Most of them are diagnosed in stage 2 or higher, and the median interval time from diagnosis to cervical cancer to cardiac metastasis is 10 months. From a review of the literature based on a collection of case reports and case series, we can see that when cervical cancer metastasizes to the heart, it's a very poor prognosis, and thus the median survival based on these case reports is between 1 and 13 months. Now, endometrial cancer is the most common gynecologic malignancy. However, only 2 to 4% of them are diagnosed in stage 4. The most common sites of distant metastasis are the lungs, followed by the liver, brain, and bone being other common sites. In terms of cardiac metastasis, it's only limited to very few case reports. which I've summarized in this table. So for only one patient, the cardiac metastasis was found at the time of presentation of her endometrial cancer. She had right heart failure at diagnosis and was found to have a large mobile mass involving 80% of the right ventricle. She underwent primary surgery for the endometrial cancer, lymph node dissection, and cardiac. And then for the cardiac tumor, she didn't have surgery. She had a cardiac radiation followed by cisplatin and calyx for a year, and she had no evidence of disease at 6.8 years. The other 4 case reports that I found were all diagnosed after the primary surgery for endometrial cancer. All were found with a mass in the heart and all had very different treatments. So one patient had no treatment and died 17 days later. And then there was a combination of chemotherapy, palliative radiation, and hormonal therapy, and all patients died within a very short time span. Here's another case of a 56-year-old female who was admitted with exertional angina and dyspnea lasting 3 days. Her medical history included hypertension and metastatic leiomyosarcoma, and she underwent primary surgery and radiation therapy 7 years prior. When she presented, her examination showed a grade 4 pansystolic murmur at the apex and a 3 by 3 centimeter mass in the right lower quadrant. On transthoracic echo, she had severe mitral regurgitation, a 6 by 7 centimeter mass compressing the left ventricle, and the images are found here, and this was her EKG on presentation. And the final diagnosis for this patient was a giant left ventricular metastasis of a uterine leiomyosarcoma, mimicking acute coronary syndrome. So uterine leiomyosarcomas are aggressive smooth muscle tumors. They represent 1% of all genital tract cancers and correspond to 3 to 7% of all uterine cancers. The mainstay of treatment is surgery. However, it harbors a very poor prognosis. The 5-year survival is between 18.8% and 65% across all stages. Next, we present a case from our site, which is a patient who at the time of presentation was in her 50s, and in May 2012 was found to have a tumor invading the heart and into the pulmonary artery. 7 years prior to presentation, she underwent a hysterectomy for a benign fibroid, and unclear if at the time, based on the notes in the chart, whether at that time the tumor was already invading the iliac vessels. However, on presentation in 2012, her MRI showed a right adnexal mass, a tumor versus a thrombus in the gonadal vein extending up to the IVC and into the right lobe, into the right atria, and into the right pulmonary arteries. The plan was a multidisciplinary plan for surgery between vascular surgery, cardiac surgery, and gynecologic oncology. So in June 2012, she underwent the following procedure. She had a midline laparotomy and a median sternotomy. Mass was in the right lower quadrant, involving the entire gonadal vein, extending to the IVC, the heart atria, and into the pulmonary arteries. In the surgical procedure, the right colon was dissected medially. The mass was adherent to the right pelvic sidewall peritoneum, and the ureter was identified, dissected from the gonadal vein, and ultimately the mass was dissected off the colon mesentery. And then the only attachment of the mass was to the IVC. So that was the pelvic part and resection of the mass in the gonadal veins to the IVC. And just to clarify as well, the mass was on the right side in the pelvis. So once the pelvic portion was done, the cardiac surgeons put a non-plegid monofilament suture into the ascending aorta and into the right atrium, and then the cannula was placed into the superior vena cava. An echo was performed at the time and showed that the tumor was very mobile within the right atrium, and therefore a cannula was not placed in the right atrium. The tumor was removed and the patient was off bypass, and the overall time of bypass was 5 minutes. Hemostasis was obtained, the protamine was reversed, and the pericardial sac was closed after placing one pericardial and one mediastinal tube. So overall, the tumor this was the image of the pelvic tumor, and the tumor was removed, as we can see in the central image, in a single piece. They also noted that there were evidence of tumor fragments in the pulmonary vessels, as seen on CT, and those were completely resected as well. And we can see here a final picture of the final dissection, which was complete, and all tumor was removed. Following this procedure, how the patient evolved was initially she always had lung nodules. And over the course of her disease illness, these nodules progressed in size. However, in order to achieve treatment, complete resolution and complete treatment of these nodules, she would require a right lung transplant for resection, which was deemed very morbid, and also the patient did not agree to that. So she was followed for those lung lesions over time. In December 2012, so 3 months after the initial surgery, she had a sternal infection requiring sternectomy with pectoral muscle flaps. In 2016, she had a recurrence of the pelvic mass, which was 3 centimeters and was asymptomatic at the time. And given the fact that she had disease again in the lungs, nothing was done at the time, and she continued to be followed. In 2018, there was a growth of the pelvic mass to 4 centimeters. Again, she was asymptomatic, and there was discussion of giving her fibrostal, which is a progesterone modulator that we commonly give in gynecology to patients who have benign fibroids. And at the time, her disease was found to be a Leomyomatosis, so rather benign, although aggressive course, but not malignant. In 2019, there was a plan to remove the cardiac lesions that she had along with the lung nodules that were followed. However, the patient declined. And the plan was to undergo cardiac catheterization and resection of the right ventricular outflow tract and pulmonary mass, but the patient did not agree. And then in September 2020, in June 2020, there was an increase in the size of the pelvic mass, causing pain. And however, for the lungs, the only option was a lung transplant. And so preoperatively, because she started to have pain in the pelvis, the decision was made to remove the mass in the pelvis. However, the safety of the procedure, given her lung mass and her cardiac mass, there was a discussion whether we can resect the pelvic mass. Therefore, preoperatively, she had a transthoracic echo, and there was no gradient across the tumor, so it was deemed safe to proceed with a surgical procedure in the pelvis. And I was involved in this case with Dr. Bernardini. So on September 12, 2020, she underwent a resection of the pelvic mass, and the mass was in the peritoneum, originating from the stump of the infundibulopelvic ligament. We dissected laterally to separate the mass of the external iliac vessels, as well as the psoas mass. Immediately, the sigmoid was adherent to the mass. However, we were able to identify the plane and successfully resect the mass. And of note, during the procedure, the patient had a intraoperative cardiac echo, a transthoracic echo, which was normal throughout the procedure. The pathology revealed a sarcoma with myogenic differentiation. Here is another case from our center as well. It is a 42-year-old female who had a previous hysterectomy for a leiomyoma. She presents with a left adnexal mass and IVC thrombus. The CT, however, was reviewed at our center, and it revealed intravenous leiomyomatosis with extension to the left gonadal vein, left renal vein, IVC, and hepatic vein up to the right atrium. So she underwent surgery. She underwent a left oophorectomy, left gonadal vein resection, right hepatectomy, infrahepatic and retrohepatic vena cava resection and reconstruction, and reimplantation of the left and middle hepatic vein in September 2019. Postoperatively, she developed partial occlusion of the IVC graft and intra-abdominal collection. Here is a picture of the specimen, and the pathology showed IV leiomyomatosis, and the outcome was no residual disease. So the previous two cases were of intravenous leiomyomatosis with cardiac metastasis. So although rare and histologically benign, you can see that the course is a biologically aggressive tumor, although the histology is non-malignant. There are two theories as to where the leiomyomatosis originates. So it's either thought to be a uterine leiomyoma, which then extends, or begins in the venous walls of the uterine veins and grows within the venous channels without necessarily invading them. The mainstay of treatment is complete surgical resection, and that is the key to preventing recurrence. Based on a literature review, there was a literature review that summarized 194 cases from 1974 to September 2012, and they determined that the most common age is in the fifth decade, and the mean age is 50 years old. Most of the patients in their review had undergone a previous hysterectomy, myomectomy, or had coexisting uterine leiomyomas when admitted. Based on the table that we can see on the right side, the most common presentations were dyspnea, syncope, or edema in the lower extremities, and the most common routes of extensions were the iliac veins, ovarian veins, or renal veins. Usually on preoperative examination, a transthoracic echo, CT, and MRI are usually useful in preoperative diagnosis and surgical management. So based on this review of these 194 cases, they performed the survival analysis and compared patients who had complete versus incomplete resection. And you can see here there's a significant difference in PFS in those patients that were not completely resected, and their hazard ratio was 0.029 as compared to the overall survival, which there's a smaller gap between the two curves, but still a significant difference in overall survival. In patients who are incompletely resected, there is a possibility to give adjuvant hormonal treatments such as tamoxifen or Megace, and they found that there was no difference in survival with those that had anti-estrogen therapy versus those without anti-estrogen therapy. The differential diagnosis, again, for these cardiac masses include a right atrial myxoma, a thrombus in transit, a renal cell carcinoma, a Wilms tumor, intracardiac leiomyomatosis, benign metastasizing leiomyomas, and metastatic cardiac tumors. In fact, 30% of the patients in this case series report, a review of the literature, found that 30% of patients were misdiagnosed preoperatively as having a right atrial myxomas. So the surgical approach to resection of intravenous cardiac leiomyomatosis is the incision is a combined thoracic and abdominal incision. The right atrium is open to reveal the intracardiac leiomyoma. The IVC is incised to reveal the IV leiomyoma with cardio bypass support. After separating the site of the intracardiac or intravascular adhesions under full control of both sides of the tumor, the intravenous cardiac leiomyoma the way it's extracted depends on the morphology of the tumor. So the extraction is upward. It was upward in 17 out of 59 of the cases in the literature review. And the upward resection is if there is intracardiac inflation only, or downward from the venotomy if there is no inflation or adhesion. Segmental resection was done in 20 out of 59 of the cases presented, through which the tumor segments can be resected from the atriotomy and the venotomy, and can also be considered if multiple inflation or adhesions exist. Complete resection of the intravascular and extravascular portions of the tumor is mandatory to relieve symptoms and prevent recurrence. A single stage or a two-stage procedure with cardiopulmonary bypass can be performed and have been used for resection of the tumors depending on the lesion and depending on the surgical team planning. The advantages of a one-stage operation is that it decreases the risk of tumor embolism, tumor progression, and hemodynamic complications in the interval between surgical cases and avoids the need for a second operation. When there is invasion of the vena cava wall, there is partial or complete resection of the vein wall, and subsequent reconstruction may be necessary. In order to obtain vascular control, temporary occlusion of the renal veins, gonadal veins, contralateral iliac vein, and if necessary, a Pringle maneuver can be sufficient. And alternatively, one can put the patient under hypothermic circulatory arrest. In a surgical approach without a sternotomy, this could be an option that can be done by resecting the leiomyoma from the point of attachment in the abdominal portion of the IVC. The patient is positioned for an anterolateral approach and can identify the IVC. We can obtain vascular control with a vessel loop superiorly and a vascular clamp inferiorly to the tumor and extracted with an ellipse of the IVC. The next case is a case of a 61-year-old female with a large tumoral infiltration extending from the pelvis through the IVC into the right atrium, protruding into the right ventricle and to the right ventricular outflow tract. 10 years prior, she had a low-grade endometrial stromal sarcoma treated with hysterectomy and followed by hormonal and radiation therapy. And so basically here we can see her transthoracic echo presents with a large tumor infiltration through the pelvis, from the pelvis through the IVC and invading the right ventricular, the right ventricle and the right ventricular outflow tract. And we can see here on her CT scan the mass and the IVC infiltration. So here we see that the patient underwent a two-step procedure, which was performed 25 days after the initial surgery. The tumor's basal part was found in the right iliac vein. She underwent a venotomy at the junction of the iliac vein and IVC. Simultaneously, a right atriectomy under ECMO was performed. The solid tumor mass was found in the right atrium, contiguous with the tumor filling the IVC. A portion of the tumor in the right atrium branched into the right ventricle through the tricuspid valve, making a Y shape. And the branching part of the tumor was extracted from the right ventricle through the tricuspid valve. The tumor was completely pulled out through the IVC, and the final specimen, which we can see here, measured 33 centimeters and was grayish-white, cylindrical shaped, smooth, and hard, and which is the usual presentation of how leiomyomatosis, intravenous leiomyomatosis presents. So to summarize endometrial stromal sarcomas, they are more aggressive than intravenous leiomyomatosis and have a greater propensity for local invasion and systemic metastases, and of course, they are malignant. The final cancer that we'll review is ovarian cancer. When we refer to ovarian cancer, the most common type and the most aggressive type is the surface epithelial types of ovarian cancers, and the ones that we refer to the most are the serous cancers. And I reviewed the literature. There were no cases of invasion into the heart related to sex-scored stromal tumors or germ cell tumors. So I'll focus the next part of the presentation related to high-grade serous ovarian cancer. So high-grade serous ovarian cancer, the mainstay of treatment is achieving surgical resection, complete surgical resection, and deciding which patients are amenable for a primary cytoreductive surgery as compared to neoadjuvant chemotherapy. Most of the cases present in stage 3 or 4 disease, and we are wondering in patients who have stage 4B disease, there is a question of benefit of cytoreduction versus neoadjuvant chemotherapy. If we're not able to completely cytoreduce all of the tumor, then the patient may benefit from chemotherapy. However, if there is a possibility of resecting even distant metastases, then this patient may benefit from increased survival. So here is the CT of a patient with high-grade ovarian cancer who presented with a 1.8 centimeter cardiophrenic lymph node. And the idea is that if the rest of the abdominal and peritoneal and pelvic disease could be resected, then making the difference in her survival, if we leave this tumor behind, that's more than 1 centimeter, she would be suboptimally cytoreduced. So we would give her chemotherapy preoperatively. However, if a surgical consultation deems that this tumor is resectable, then she can be cytoreduced to no visible disease and benefit from increased survival. And the question as well is whether that cardiac lymph node ends up being metastatic or not on primary pathology, which would then upstage the patient into stage 4B. So in the review of the literature, there was a prospective series of 196 consecutive patients with epithelial ovarian cancer undergoing primary cytoreductive surgery in a 2-year period. So the suspicious cardiophrenic lymph nodes are over 10 millimeters on preoperative CT. And as I mentioned, they were removed if the rest of the cytoreductive procedure resulted in no gross residual disease or optimal less than 1 centimeter cytoreduction, and if the patient's performance status allowed a surgical procedure. So 15% out of those 196 epithelial ovarian cancers had suspicious cardiophrenic lymph nodes on preoperative imaging, and 90% of these had at least one positive cardiophrenic lymph node on pathological examination. And they also found that cardiophrenic lymph node dissection is cardiophrenic lymph node is associated with extensive intra-abdominal tumor spread in the upper abdomen, so very seldom an isolated lesion. So the procedure to remove the cardiophrenic lymph nodes involves full exposure of the diaphragm peritoneum after mobilization of the liver. The diaphragm is excised using electrocautery. The pleural space is explored. The cardiophrenic nodes are resected using a vessel sealing cutting device. The 15 French JP drain is used as an alternative to the standard chest tube and placed to the through the diaphragmatic defect. The diaphragmatic defect is then closed using a non-absorbable suture. So they suggest 2,0 polypropylene in a figure of 8 fashion. The JP drain is connected to suction to evacuate the pneumothorax, and then you perform a bubble test to make sure that the diaphragm is completely closed. The morbidity and oncologic outcomes of this procedure were reviewed in the literature. So a case series of 54 patients was done in patients undergoing cardiophrenic lymph node resection. And 94% of these lymph nodes ended up being positive on pathology. And in the patients, 100% of them were at least optimally cytoreduced, and 55% of them had no gross residual. In terms of morbidity, 94% of them had a chest tube placement, and the median time to removal was 4 days. In another case series, the most common postoperative complication was small pneumothorax. In this series, there was a 35% rate of major postoperative complications, and 4 out of these were surgery related. And the median time to adjuvant chemotherapy was 40 days. The median PFS was 17.2 months, and the median overall survival was 70 months, which is very good for a high-grade ovarian cancer. Kleiby and al. Reported on the oncologic outcomes based on a Mayo Clinic cohort of 250 patients. There was recurrence was found in 81.5% of those patients with abnormal preoperative cardiophrenic lymph nodes, and abnormal cardiophrenic lymph nodes were more likely to be associated with synchronous recurrence in the thorax, pelvis, and abdomen in 50% of the cases. And all patients who had a CT scan after 6 cycles of chemotherapy had improvement in cardiophrenic lymphadenopathy. So in summary, gynecologic metastases to the heart are exceedingly rare. A common presentation is a presentation of is as a CHF, and commonly women have a previous history of having a hysterectomy, and therefore when a woman presents with CHF, in very rare cases, sometimes you may have to investigate other symptoms. So again, just to summarize in an illustrative fashion, so the cervix, based on literature reviews, we know that cervical cancers metastasizing to the heart have very poor prognosis, and the question is, do we give palliative radiation versus chemotherapy? Endometrial cancers are exceedingly rare and based on only case reports and have a poor prognosis, and the treatment is debatable between chemotherapy, radiation, possibly calyx. The ovary, we found that with resection of the cardiophrenic lymph nodes may achieve complete cytoreduction and may assist in increasing survival. For leiomyomas and intravenous leiomyomatosis, the mainstay of treatment is usually surgical, and the treatment plan should be made in a multidisciplinary fashion, planning a one-stage or a two-stage procedure, and there's questionable benefits of a adjuvant hormonal therapy. So on this, I conclude our presentation on gynecologic tumors metastasizing to the heart, and I'm open to take questions or any comments on this topic. Thank you very much for allowing me to present today.
Thank you very much. That was very complete. Please, everybody, if you have any questions, ask them on the chat. I was a little bit confused about the stromal cell, because I'm not a gynecologist, stromal cell versus endometrial leiomyomatosis. What's the difference between the two again?
The intravenous leiomyomatosis is a benign version. So it's like a fibroid, like about 70 to 80%. It's very common in women, between 50 to 70%, to have uterine fibroids, but to have intravenous leiomyomatosis is much more rare. So it's a benign histologic pathology, but it acts very aggressively. Whereas an endometrial sarcoma that actually originates from the endometrial lining and is malignant from the get-go.
That's the stromal cell tumor you were talking about.
Yeah.
And because you mentioned in that this is how leiomyomatosis, they're not necessarily that one invades the wall and the other one doesn't. Can you get leiomyomatosis invading the wall and stromal cell not?
I'm not sure about if stromal cell can invade the wall. I think it's only based on some case reports, but what I read is that the leiomyomatosis doesn't invade the wall of the IVC, but maybe vascular surgery could be more experienced with this.
And it's quite interesting that a benign tumor has such a horrible outcome when it's not completely resected. And when you say incompletely resected, what are you talking about? Are you talking about the pelvic portion being incompletely resected, or what do you mean?
So any portion. So if you left a part in the IVC. So for example, the first case, that it was a joint case with you initially and Dr. Bernardini and a few other people. So there was some notes that she had some fragments in the pulmonary arteries as well that were also resected. So let's say we had left one of those behind, or like the portion in the atrium. From what I understand, leaving those behind could affect worse prognosis. For example, if not by purpose, you will leave them behind, but if they were not able to be resected, those patients have poorer prognosis. It's unclear whether they can benefit from adjuvant tamoxifen or Megase, but that's what's commonly used. But again, these are exceedingly rare cases.
And the pelvic portion, those pelvic portions, if you leave the pelvic portion, does that adversely affect outcome as well? I see Dr. Bernardini is here too. You may want to comment as well. Sorry to take the question away from you, Sabrina, but you've had all the fun so far.
Oh, and I think Sabrina, that was a great overview, in fact, of a rare phenomenon in all cases, but certainly have been reported in a number of gynecologic malignancies. And I think the ones that we tend to see it most are definitely these leiomyomatosis type cases. The difference between the endometrial stromal sarcomas is they do have more of an ability to kind of invade within the wall, as opposed to the leiomyomatosis, which just kind of, in a way, it's almost if they're picked early enough. I think where we have a challenge with leiomyomatosis cases, if sometimes they're left too long and they get so large that the separation between the actual tumor and the lumen itself you have no room to kind of work with, so to speak. And we saw that case recently. The one, in fact, I know I saw Ian was on the line earlier, and that was the case that you had to do almost hepatectomy in a sense to get it all out, because we weren't going to be able to just slide it out like we can in a number of cases where you're fortunate. In terms of the pelvic disease, yes, I think if you, going back to Sabrina's point, if you're leaving any of the disease behind, you leave a nidus for further development of these tumors to grow. The good news, I think, is that we tend not to see a lot of embolisms. You'd think we'd see more emboli from them, but they seem to be continuous. They just sort of grow contiguously. We had a case recently, as you know, where we were able to clear out a lot of the upper abdominal disease going up into the heart, but when you have some of the stuff within the veins of the uterine veins and deep in the pelvic veins, there's just really no way that you're going to be able to clear those veins entirely. We've had a few of these cases recently. We're going to be following them, obviously, and see how they do. But yes, I think the expectation is their risk of recurrence is higher.
Why do you think they die from benign disease? I mean, it's pretty significant mortality rate that Sabrina showed.
Yeah, I mean, I think we have to remember that they're coming from different types of institutions, and I would probably propose that a lot of it has to do with the cardiac expertise and the center where these patients find themselves. You know, I think, you know, you had the case recently, as you know, where that person was compromised, and you were able to perform that procedure, and she recovered in the unit, and then we did a combined procedure after. I mean, again, I think a lot of centers, you just don't have that capability, and it runs the risk for those patients.
The mortality she showed, though, was not upfront. It was years later.
Well, yeah, I mean, I think in some of these cases, and so we have the one case that we saw that you're aware of, you're also involved in the case. I mean, that individual does have significant lung metastases, growths of these tumors. So it's not common. It's very, very rare. But when you have these situations where they kind of grow seemingly out of control, there is no systemic treatment that's effective at shrinking it down. There is no true chemotherapy for these because they're histologically benign lesions. So there's nothing that we can utilize. And so eventually, when there's enough burden in the right organs, if you will, then they usually will succumb to that.
That's what it is. Mike Seidman, can you elucidate us a little bit more about the pathology? How many slices do you take before you call it benign? Do you just look at 2 high power fields or 10 high power fields, or do you look at 200 high power fields?
Yeah, that's not a straightforward question. So Lyo is Lyo is Lyo. Yeah. So in general, the guideline is 1 section per centimeter. We certainly follow that guideline. I cannot speak to other centers. It's how I was trained and how I follow here. So of an N of 2, I'm 2 for 2. That particular strategy is very effective at identifying malignant components in primary things that otherwise look benign. Intravascular Lyo versus intravascular spread of pretty much any of the other lesions looks so dramatically different that it's not necessarily relevant. Plus, on top of that, as was shown, the outcome is not dramatically different. In terms of, you know, looking for an underlying lesion, I will say stromal sarcoma and leiomyosarcoma tend not to just grossly look the same way. They tend not to go up the vena cava quite the same way. They tend, ironically, they end up in lungs and then invade down. But yeah, so in terms of number of mitoses, et cetera, the IVL is graded the same way as fibroids. So there is a technically 3-step framework as long as you ignore atypical leiomyoma as a thing, which it isn't. But there's then a stromal tumor of uncertain malignant potential, which honestly, if that's intravascular, I'm probably going to already call bad, and then the sarcoma. You're muted.
One final question. The patient that was described, and I know that patient, but the patient that was described, we thought had leiomyoma, and I suspect that she had leiomyoma for all this time and was found to have a leiomyosarcoma. Do you think that's something separate, or do you think it was part of the same disease process? In other words, how often do you see these things degenerate or associated with the sarcoma?
Yeah, I mean, that was an interesting... Oh, sorry. Go ahead, Mike.
Yeah, unfortunately, I was involved in, if not the fault of, the uterine morcellation study. In general, fibroids don't hold sarcoma, don't degenerate the sarcoma. They were always sarcoma where you missed the sarcoma.
And in this particular case, RJ, I know that the pathologist went back and forth on it because she's had obviously a number of specimens removed. There was even a question mark at one point whether they wondered this was a de novo lesion of a gist. And so I think they didn't ultimately land on that. But I think that as Michael says, they tend not to change. So I think it's just sort of the nature of this particular tumor that this particular patient had.